also the Florida sales agent for Kiss Rebreathers. This is me on my Kiss Sidewinder. I'm getting ready for a cave dive there on the picture there. So that's part of my background, but why am I actually giving this presentation? The reason I'm giving this presentation is I'm also a COVID-19 survivor myself. I tested positive back in April. That's me sitting in my office about a week before wearing my N95 mask, thinking I was invincible, and found out that was not the case. I was exposed to a patient in my office in March who was coming in for an unrelated reason. He was coming in for elective procedure. About 10 days after I saw the patient, I began to develop symptoms. The patient himself, when I saw him in the office, was markedly short of breath, and I sent him right to to our urgent care. He got admitted to the ICU. He was in the ICU for about 3 days and in the hospital for about 2 weeks, but has recovered. My symptoms started about 10 days after exposure, which is a little bit late. We'll talk about that in a minute. I had fever to 102, non-productive cough, shaking chills, profound fatigue. In fact, one day I spent 14 hours in bed. One day I spent 17 hours in bed. But thankfully, I never got short of breath, never had to be hospitalized. All of my symptoms resolved after about 10 days, I thought. And I think that's important because I felt like I was probably back to normal. However, all the gyms have been closed up until recently. So I said, let me see how my exercise tolerance is. And I usually can do 30, 45 minutes on my home rowing machine without a problem. And when I thought I'd gotten better, I got on that rowing machine, and within 10 minutes, I was totally gassed. So my lungs were not back to normal yet. And I'll talk a little bit about that in a minute. But so what I did was just kind of worked on my exercise tolerance. And after about 2 weeks, I was completely back to normal. I had good exercise tolerance. I also have access to some toys that a lot of you probably don't have. I could get on a treadmill at my office with a pulse oximeter. So after office one day, I just jogged on the treadmill with a pulse oximeter to make sure I didn't drop my oxygen sats, which I did not. That told me my lungs were doing fine. And at that point, the most important part is I got back to diving. So I got back to diving in early May. So since having this in April, I've actually done about probably 20, 25 dives, to include a 3-hour cave dive in Jenny Springs and a 2.5-hour dive in West Palm Beach. So without symptoms, without problems. So I'm one of the lucky ones, and I'm back to normal. I'm going to give a little plug for our local diving. This is my first dive back after being sick. That's me with my buddy up in the upper left corner. The upper right corner is kind of how we've been doing diving in Florida, where everybody has to wear masks on the boat. The dive boats until recently have been limited to have 8 divers, 2 crew, and a captain for social distancing reasons. And the pictures I put in here are pictures I took on one dive. So this is not a best of West Palm Beach. This is one dive in West Palm Beach from May 6th, just to show you what kind of local diving we have. So if you ever want to come to West Palm Beach, I recommend coming. And Pure View to Divers down there, that's their website, is my favorite operator there. I'm not paid by them. So you'll see we have eels and Goliath grouper and both loggerhead and hawksbill turtles and an anemone with an anemone shrimp and even queen triggers and so forth. So a great dive. It was great to get back in the water in May. And thankfully, I've been able to been diving quite a bit since that time. So what is the whole thing about COVID-19 and the coronavirus? It's actually called the SARS-CoV-2 virus. This is the coronavirus that causes the disease we've called COVID-19 for coronavirus that came out in 2019. These are not new viruses. Okay, coronaviruses have been around forever. They're a spherical envelope there, like on the right, with positive strand RNA virus. They commonly cause respiratory illnesses in humans. In fact, they cause about 15 to 30% of what we would consider the common cold. They're called a coronavirus because of those little spikes. You see the little red spikes around the thing, which looks like a crown, and that's where that came from. Prior to COVID-19, there's been 2 severe outbreaks of coronaviruses in the past. There was the SARS-CoV-1, which is just called the SARS virus, and there was the MERS virus, which is a smaller outbreak, but very, very dangerous. The SARS-CoV-1, which we called SARS, was a global epidemic back in 2002 and 2003. There were about 8,000 cases with 774 deaths for a mortality rate of about 9.6%, which is much higher than we're seeing with the current coronavirus, COVID-19. A second outbreak, which is much smaller, thankfully, was called the MERS. That was another coronavirus. This happened in 2012 and was localized mainly to Asia. About 2,500 cases with a large number of deaths, 858 deaths. So that virus had a mortality rate of over 1/3. That was a horrible virus. Thankfully, it was not very infectious. It did not spread very far, So we didn't have the global pandemic like we're having at the moment. So how did this whole thing start? Well, if you guys have probably all heard this story by now, but it was a cluster of pneumonia cases were reported to the World Health Organization, the WHO, on December 3rd of last year. The WHO tracked it to a common exposure to a local seafood and animal market in Wuhan City, China. They isolated this virus. It was a novel virus they'd not seen before, and it was termed the SARS-CoV-2 virus. It's most similar to bat coronaviruses, which were a lot of the memes and stuff came out back in March of bats and so forth. I looked up the current statistics as of about an hour ago before I logged on. So data as of today, there's been over 8.7 million cases worldwide and over 461,000 deaths worldwide. So this has been a major issue, as we all know, and has interrupted life all over the globe. How is it spread? It's spread mainly by large respiratory droplets, which can occur from coughing and sneezing, but also can occur just from speaking. It's questionable as to how contaminated or how infectious something could be on a contaminated surface from fomites. That kind of waxes and wanes, but the major problem is going to be respiratory. The airborne route is also possible with certain procedures that we do in the hospital. So intubating people for surgeries, doing transesophageal echoes for cardiac procedures or endoscopies, like looking for ulcers or colonoscopies and so forth, are very high risk with upper endoscopy, TE, and intubation because of the respiratory route, such that in our current hospital, we require people to have negative tests to come in for any elective procedure, but then people coming in for those particular procedures actually get a second 1-hour test before the procedure. And then we're also wearing kind of MOP 4 looking gear for those types of procedures with multiple masks and gowns and so forth and so on for the extra risk. How does this actually work? Well, the little cartoon there on the right is an alveoli. All of us are divers, so we all know about the alveoli and concerns of overexpansion injuries with these bursting and having bubbles going into the bloodstream. This is a little cartoon of an alveoli, and what happens is the SARS virus will get into the alveoli, and our body starts to attack that, and it attacks it with the alveolar macrophages and the activated T cells. And in some people, they fight that off and they have the infection and never have any symptoms or have very, very mild symptoms. In other people, two things happen. First off, a number of the virus can be so large that it actually overwhelms the alveoli and the macrophages and T cells and extends into the tissue of the lung, causing pneumonia. And in a fewer number of people, that can then result in a cytokine storm with a massive inflammatory reaction, and that's what gets people really, really sick. The virus can then, from the alveoli, go into the bloodstream, just like we have gas exchange across the membranes. You can have all of a sudden with this disruption, virus getting into the bloodstream, and that can then cause infection and illness in other organ systems, which has been a major problem as well. This is one of our patients at the hospital. This is a normal, trust me, a normal chest x-ray on the left, other than you see these mid-sternal wires. That's from his prior bypass. And in the right upper corner, which is his left chest, is a pacemaker with a lead going into his heart. So you can see this is a normal chest x-ray, but this is an elderly man who has comorbidities. He had cardiac disease and a pacemaker. And within 24 hours, his x-ray changed to look like the one on the right. And on the right, I think what you'll see is lots of more, the areas that have been black with little faint white areas in the lungs, all of a sudden now look a lot denser. That's the pneumonia that's progressed within 24 hours. And the other thing that you would notice, if you look above those sternal wires, you see a linear density that wasn't there before. That's his endotracheal tube from being intubated. So this is a guy who walked in one day and within 24 hours had a massive pneumonia and was intubated and ended up being in the hospital for over a couple of weeks. I'm going to bring up CAT scans because we're going to talk a little bit about that with some data on divers in a few minutes. This is a normal CAT scan of the chest here on the left. That's taking a person laying down. So the top is kind of their chest, the lower is their back, and it's like you're slicing them like a slice of bread. That's the heart there in the middle, and the lungs and the little white densities you see on both sides are just the little blood vessels. That's a clean looking normal chest CT scan. On the right is examples, not a particular patient, this is examples of what goes wrong by CT scan in people with COVID-19. I think you'll notice on those top A, B, and C panels, that's the same kind of cuts as on the left. And you see all these patchy infiltrates and white areas. That's this rip-roaring pneumonia kind of overwhelming the lungs, and then other projections, lateral projections and AP or anterior projections there down below. Again, you see all the patchy stuff. That's what happens to people who get these very severe cases and end up on ventilators, and unfortunately some of them actually end up dying. So how does this work? The incubation period is around 5 days, meaning that people get infected and don't know it for a mean of about 5 days. The range is anywhere from about 2 days to 10 days. So like in my particular case, I didn't have symptoms for 10 days, but I'd been infected. So I could theoretically have been infecting other people for 10 days. Luckily, I quarantined and was wearing masks and so forth. But that's important because a lot of people, even ones who do develop symptoms, had the illness for several days probably before they developed symptoms. So there's a concern of people infecting people without even knowing they were ill. In general, the symptoms tend to be fever, what's called a non-productive cough, so kind of a cough without bringing anything up, and then shortness of breath, which can lead to rapid breathing and so forth. People who are short of breath and rapid breathing, those are people who should definitely present to medical attention because like I showed you on that chest x-ray, that can progress very, very quickly. If respiratory failure is going to occur, it usually happens about a week to 10 days after symptom onset, but that can be highly variable, like as mentioned in that slide earlier. I mentioned it's usually a respiratory illness with the lungs involved. However, it can affect other structures as well. It can affect the heart. I bring that up not because I'm a cardiologist, but because that can be a major issue and something we need to be aware of in diving. When it affects the heart, it presents what's called a cardiomyopathy. That's a fancy word that means a weakened heart muscle. And this weakened heart muscle can lead to very dangerous heart rhythms like ventricular tachycardia, the thing you see on the medical shows right before people arrest with their little wavy lines going very, very quickly. So what happens if you look at the top right little panel there of normal heart, if you look at the side there with the arrows, that's kind of a normal sized left ventricle, which is the main pumping chamber of the heart. If you look on the one that says dilated ventricle, you see that chamber is much, much larger. And what happens is the heart goes from the ventricle being shaped more like a football, which is a very efficient way for it to pump, to being much rounder like a basketball. And that's not a very efficient shape for the heart for pumping. So people get a lot of problems with weakened heart muscles, more problems breathing, congestive heart failure, and that weakened heart muscle can set them up for dangerous heart rhythms. Additionally, what we have found with this virus, like lots of other viruses, is it can lead to what's called a hypercoagulable state. That's a fancy term that means the clotting system is activated and people are very prone to form clots. That also happens with lots of other viral illnesses like HIV, dengue fever, and Ebola. Back in the day of the SARS-CoV-1 epidemic, this resulted in what's called disseminated intravascular coagulation, which is basically clotting off all kinds of organs. Blood DVTs or blood clots in the legs, and pulmonary emboli are then those blood clots go into the lungs. And we're starting to see that also in the COVID-19 patients, where they can form clots in the arterial system, which can lead to strokes, loss of limb. There's the classic finding where they've been talking about the lungs of that Broadway actor who lost a leg. And then they can also have clots in the venous system, which would be blood clots in the veins of the leg, which can then progress to causing blood clots in the lungs, pulmonary emboli, which can be fatal as well. So it's mainly a respiratory illness, but can go into other organs as well, and something we need to be aware of. When this first came out, people said, oh, it's just the flu. And this is clearly not just the flu. If you look at this chart, the x-axis, the horizontal axis, is what's called the basic reproduction number. I'll talk about that in a minute. That's basically a marker of how infectious something is. But what we're looking at on this slide is the vertical axis, which is the mortality rate. So you see things like rabies untreated is got 100% mortality. HIV untreated has got an 80 or 90% mortality. Then as you move down, you see tuberculosis, Ebola, the MERS, we talked about 33%, smallpox, polio. And you see COVID and influenza down there. If you blow up COVID influenza on the small inserted graph, the mortality for influenza is about 0.1%. The best we can guess on COVID-19, I'll talk about this on the next slide or two, is this probably has a mortality closer to 3 to 3.5%. So you're talking an order of magnitude higher mortality with COVID-19 than we have with the normal flu. So if you compare the flu and COVID-19, again, the R0 number that we're talking about, that's how infectious this is. What that means is how many people does somebody who has this illness infect? So the flu, everybody that has the flu will infect a little over more than one person. If you can have a disease, once you get that number less than 1, the disease will go away. So what we're trying to do in COVID-19 with all of this social distancing and wearing masks and so forth is try and get everybody who's sick to infect fewer than one person, and this will go away. COVID-19 is currently at about a 2 to 2.5 kind of infection rate. The incubation time for the flu is a couple of days. Like we mentioned, for COVID-19 is somewhere around, usually around 2 to 10 days. Hospitalization rate is about 2% for the flu, with a mortality rate of less than 1. And the hospitalization rate for COVID-19 is about 1 in 5, with a mortality rate maybe as high as a little over 3%. One thing we aren't sure of is exactly what the mortality rate is. And the reason for that is because of testing. Initially, when we didn't have a lot of people tested, all you knew is your numerator was how many people died, and the denominator was how many people you had known that tested positive. But there may have been a lot of other people out there who were infected, didn't know it, and that would make your denominator much larger, so your percentage, your death rate would be much lower. So currently we're around 3.5%. It's probably going to be, when this all settles out, maybe somewhere between 1 and 4%. But even if it's down as low as 1%, that's still 10 times higher than the risk of dying from the seasonal flu. The people, as we all know, that tend to be the most problematic are people either with underlying illnesses or especially the elderly. And in Florida, we've had huge problems with nursing homes and nursing home deaths. If you look at the age breakdown, fatality rates, as long as people are under the age of 50, the likelihood of dying from this illness is extremely low. Once you start getting into your 50s and 60s, it starts having a significant kind of mortality rate. You get into the 70s, and especially in the 80s, it's got a very, very high mortality rate. So that these are the people that clearly should be sheltering in place and so forth, even when things are opened up, because if, God forbid, they get this disease, they've got a very high mortality. Whereas if the 20-year-old gets this disease, the likelihood of mortality is actually quite low, though it does happen, obviously. This is kind of how that infection works. If one person infects 2 people, those 2 people infect 4, those 4 get 8, those 8 get 16, and that's kind of how this has rapidly spread, especially when you start throwing in international travel and so forth that was happening from January through March. This spread worldwide very, very quickly. From the contagion standpoint, just to give you a general idea of how contagious that is, this is talking about that R0 number we were talking about. Steve, you just came on my screen here. Let's see. There we go, catch up. So an R0 number is basically how infectious is something. So if you look at on this, the picture on the left, or the little bar, the little columns on the right, things like measles are incredibly infectious. Everybody that gets the measles will infect 12 to 18 people. Things like polio, smallpox, diphtheria, rubella, measles, mumps, all that kind of stuff was going to be 4 to 7. Yeah.
I'm sorry to interrupt. We can't see your screen anymore. Can you share it?
It should be on there. Sorry. Let me try it again. I think they may have kicked off. Let's see. Are you there now?
I can see it. Yep.
Okay. Sorry about that. Somehow I got bumped off. So anyway, so I was looking at this little chart here and so forth. So things like polio, rubella, mumps, and so forth, everybody that gets infected will infect 4 or 7 people. The COVID-19, like I said, is more like around 2 to 2, maybe 3 people get infected. So it's more infectious than certain illnesses, but not as infectious as lots of things could be. And like you remember, I told you the MERS, which had the very high mortality, the smaller numbers, but high mortality of 34%. Thankfully, the rate of infectivity was 0.3 to 0.8. So that's why it never became a global pandemic, thankfully. Okay, so what are the current measures in the United States? We all know this. Travel restrictions and screening. There's screening people left and right. You can't get into certain places without having your fever checked. Obviously, airports and so forth have been shut down for a long time. Certain countries are still shut down, and things are slowly loosening up. Additionally, by isolating cases and doing contact tracing and quarantining people, we're trying to prevent the spread. Again, trying to keep that R0 number, that infectivity number, as low as possible. That's also where the social distancing comes in, because of the fact that it's mainly spread by respiratory droplets. Those droplets shouldn't stay in the air more than about 6 feet. So that's the idea, of staying 6 feet away from everybody. So even if you had droplets, they would land on the ground before they infected someone else. There's a lot of controversy about masks. I'm sure everybody knows masks in general are not going to do, other than the really fancy ones like we'd have in the hospital. Regular masks are not going to do anything for keeping you safe, but the idea is that you should be able to block some of those particles coming out of your mouth if you happen to be infected but didn't know it. So hopefully that would decrease the likelihood, at least somewhat, of you infecting someone else. So if other people are doing the same thing, that allows them to have a lower incidence of infecting you. So this is kind of one of those one for all for one kind of things. We're trying to do our part to keep from infecting someone else, while vaccines and therapies are currently under development. I'm sure all of us are tired of the term flattening the curve, which none of us heard prior to about March. The concept of that flattening of the curve doesn't do anything for the total number of cases. The same number of people are probably going to end up getting infected. The issue was overwhelming the medical system. So the idea, let's say for argument's sake, that the number of ventilators we had in the United States was somewhere in a horizontal line just above where it says social distancing. Well, if we didn't do any kind of social distancing, sheltering in place and shutting down airports and so forth, this epidemic would be like that red curve. It would have peaked at about 3 months, and then it would have kind of died off within 7 or 8 months. Everybody would have been infected. We would have had herd immunity. People would have died, but at least the pandemic would have been over. The problem, though, you see, is the number of cases would be way above what the medical community could handle. And that's what happened in Italy. So Italy got overwhelmed. They had more patients needing ventilators than they had ventilators, and doctors were put in a very bad situation of having to decide who to put on a ventilator and who to let die. That's what we did not want to have happen in the United States, and thankfully that did not happen. Even in New York City, they managed to keep it low enough for that not to be a problem. So what that does is, by flattening the curve, we basically spread out the number of cases. So the same number of people probably get infected, but it's over a longer period of time, so you don't overwhelm the medical system. So it's not surprising at all that as we've loosened restrictions, the number of cases are increasing. They're not increasing to the point where overwhelming the medical system again, but again, that's not surprising that cases are now going up, because there's that blue curve, the risk of resurgence following lifting of interventions, and the curve goes right back up again. So that's why we're expecting this thing to last probably around a year or so, because of just the mechanics of how that curve works for us. Okay, that's enough background on the illness itself. The reason we're all here is because we want to know what's happening in diving. So the common diving questions with COVID-19 are the following. We want to know, can this be spread underwater? How do we effectively disinfect our gear to not get other people infected and not get infected ourselves? How do we safely resume diving when the world kind of opens back up? What changes do we need to make in our dive training? And then when can someone who has contracted disease return to diving safely? So first off, can it be spread underwater? We don't know for sure. The data we have is mainly based on the SARS-CoV-1 virus, the regular original SARS virus from 2002-2003 that was studied. And it is harder to kill than is the CoV-2 virus. So the data on CoV-1 probably will apply or should apply to CoV-2. Chlorinated or bromated pools and hot tubs inactivate the virus, so that's not a problem. So getting in a pool or getting in a hot tub or doing dive training in the pool is not a problem, as long as you maintain social distancing and you're not spreading things by close contact. The pool itself will inactivate the virus. At least with the CoV-1 virus, the virus could be infectious for long periods of time found in surface water. So in lakes and rivers, they found it's still infectious. There's been some preliminary data that is probably also true for CoV-2. So if you're diving, you probably should try not to spend a lot of time on the surface. I'd get in the water and get down if you're in freshwater diving. For salt water, we have no data, but the suspicion is it's not going to do well in salt water, and things are so spread out with currents moving and the vast size of things, you're unlikely to get infected from the water, but we don't know that for sure. Okay, how do we disinfect our gear? Now it's interesting because I can't speak for your dive shop, but a lot of dive shops over the years, as far as rental gear or in pool training, after everybody was finished, they just kind of rinsed everything off and hung things back up for the next class. That probably was not the right way to be doing things, and has been now on everybody's mind because of COVID-19. So a positive is probably the way we've changed things. So the recommendation is that by the way, there's a difference between sanitizing things, which is kind of cleaning it, and disinfecting it, which disinfecting would actual inactivate the virus. So the recommendation is we should only use disinfectants which are listed on what the EPA's list in, and they've all been tested. You can look you can look up all the products. It's a little bit of a clunky website. I'll be honest with you, it's not very user friendly, like most government websites. But that's the link there to how to get to it. And the examples of things that are effective against COVID-19, there's two forms of maticide, both maticide 1 and maticide FD inactivate the virus. There are two formulations of Simple Green, Simple Green D Pro 5 and Simple Green Clean Finish, which is in a spray bottle, are effective. Virkon S is effective. Interestingly, stearamine, which is what I've been using for 15 or 20 years on rebreathers, is not on the list. That does not mean that it is ineffective. That means it hasn't been tested and proven to be effective. So for the current time, we probably should use either maticide, Simple Green, Virkon, or something else on the EPA list until we have more data on stearamine. Or if you have a product that you're using, I'd recommend checking the EPA website and making sure it's effective against that. That's mainly going to be for equipment that's going to be used by multiple people. If it's your own equipment that only you are using, that's not a big deal. The major issue is if you're renting gear, how do they disinfect it? Or if you own a dive center and you're renting gear to other people, or you're having students using rental gear, and then how do you disinfect it before the next people use the product? And this is also a good time, in the old days as an instructor, we would basically send students home from the pool and we would stay behind and clean everything up. This probably would be a good idea to get students involved in disinfecting the gear for two reasons: teaching them the importance of disinfecting the gear, and also for just consumer confidence that their dive shop is doing this correctly. And that's one of the big aspects just for consumer confidence. Another thing you can use is bleach. Bleach is quite effective. It's also quite toxic. If you're going to use bleach, the mixture is 1/3 of a cup and 1 gallon of water. It needs to be contact time of 1 minute. Then you rinse everything, let it be dry. Regardless of which product you use, it's very important not to then reinfect gear or disinfecting. You can imagine if somebody has cleaned gear nicely, but they're asymptomatic themselves, don't know that they've been infected, they don't have a face shield on, and they've been rubbing their eyes or coughing on their hand or whatever, and touch that gear, they can then reinfect the gear after it just got disinfected. So you have to disinfect the gear and be very, very careful as kind of how you put it back, hang it back up. One of the issues with all of these disinfectants up until recently is they're all very, very toxic to the environment, and we're all trying to be as green as possible. So interestingly, just earlier this month, probably about a week ago, a new product came out called Good to Dive. It was done in combination with Fourth Element and the Diver Medic. It's environmentally friendly, powder-based, very strong oxidative product. Just announced earlier this month. It's made by putting 1 tablespoon in 1 gallon of water. I talked to the owner of Fourth Element. He told me it's been shown to kill other coronaviruses. They have not yet tested it against CoV-2. They expect that it will work, but that's one to look out for. I would hope that if that can be shown to be effective against the virus, that would have kind of two good sides: one, effective to kill it, and secondly, not as bad on the environment as the other products that we have out there. So just be on the lookout for that. And kudos to the Diver Medic and to Fourth Element. Okay, so how do we save?
Quick question.
Sure.
Lisa Evans asked about rinse tanks.
Okay.
Wants to know if that makes. I'm assuming that spreads coronavirus pretty rapidly if multiple people are using the same rinse tank.
It would depend on what you're talking about with a rinse tank. If you're talking about a rinse tank that's got disinfectant in it, that would be fine.
Okay.
You could, in other words, at the end of a class at the pool, you could have 5 gallons tank of disinfectant water, put everybody's stuff there. That would inactivate all the virus. I would not use communal freshwater rinse tanks. And in fact, in Florida, they are no longer allowed to have communal mass buckets for that exact reason. So if you're talking about multiple people using a rinse tank that has got approved disinfectant in it, I would not be concerned. If you're talking about just using a rinse tank of fresh water, I would recommend against that in this day and age.
Perfect. And then I have another question from Gregory. He asked, what is the contact time for disinfectants approved by the EPA? I do know that is on the EPA site. It's
on the EPA website. It varies from between about 3 minutes and about 10 minutes.
Perfect. And I sent everybody that link as well.
Yes, if you give her that link. The bleach is the shortest at 1 minute. A lot of them are 3 minutes, and they go as long as 10 minutes. Nothing is any longer than 10 minutes. Awesome. So if you put everything in at the end of a dive class, or maybe 5-10 minutes, you're probably in pretty good shape. If you go on the EPA website, it gives the contact time required for each of those individual products I was mentioning. So you can find it on there.
Thank you.
Sure. Okay, so in this day and age, so now we're starting to loosen things up. I mean, how do we safely resume diving? I mean, diving will never be back like it was before. I hate the term new normal, but that's what everybody keeps using. So what is going to be our new normal? For dive centers, how are we going to do this safely as we open up, both for actual medical safety, but also for consumer confidence and getting people back in our stores and back confident to take training? We'll probably need to have fewer students in classrooms, fewer students in the pool, consider more online academic training. And then also from a store standpoint, we need to be realizing that we need to disinfect items that are commonly touched by customers, like trying on masks, looking at snorkels, all that. So once people have taken something off the shelf and checked their mask to see if that fits, they decide, okay, I'm not going to buy that one. Let me check another one. That mask then needs to be wiped down and disinfected before being put back on the shelf, just again, for being extra safe for our customers. For dive charters, there's lots of different ways to do this. I'm going to tell you the way South Florida has been doing it, because that's been my experience. We opened back up for diving here in Florida in May with lots of restrictions in South Florida. Currently, face masks are required for all crew and all guests whenever they're on the boat. And you don't have your regulator in your mouth and your mask on your face. You have to have a face mask on at all times. They've had fewer divers on boats. The limit, it just changed this past week. Up until then, it was 8, like I mentioned in the photo I showed you earlier, even though the boats could normally hold 20 or 25 people. They've currently increased that, I think, to 14 on the larger boats. So it's still limited. Like I mentioned just a second ago with the questions, no bass buckets, so that we don't have any kind of communal sharing of mass buckets. And then divers are required to put their masks on, regulators in their mouth for the entire time when they stand up from their spot till they get into the water. And then upon returning to the boat, as you should anyway, mask on the face, regulator in the mouth until you get back to your spot. And the staff is getting all the drinks and snacks and so forth for customers to avoid multiple people touching things like coolers and water jugs and snack containers. So if somebody wants water, they ask the staff will go get them a cup of water. If between dives somebody wants a bag of chips or whatever, they show them the container and say, which one do you want? And the staff gets it. That way there's just one person touching everything rather than multiple people touching and spreading the virus. So I'm not saying that's right. I'm not saying that's wrong. I'm just saying that's how it's being done currently in Florida. And I'm sure every location will do things a little bit differently. Additionally, for retailers and for dive shops and so forth, DEMA just announced this, I think, within the last week. If you go to DEMA.org and you're a member of DEMA, they've actually got 3 phases of how to get people back into diving. So the first one was phase 1. That's for retail recovery, for people who just kind of help people with e-commerce, contactless curb pickup, at-home deliveries, all those kind of things that some stores were not comfortable doing and didn't have not a lot of experience in. So this is a group of, I think it's something like 7 dive shops from around the country that all kind of sat on this committee and kind of came up with a plan. The second phase, phase 2, is when the stores themselves actually reopening and allowing people in, but how to do that with social distancing and reduced occupancy. And then there is a phase 3 for people creating their own new normal and when restrictions have been lifted. So for anybody here who is in the dive industry, has a dive shop, or anybody that's there at Weaver's Dive and Travel, if you're a DEMA member, if you go to DEMA.org, and I know Steve would know all of this because he's on the board. But anyway, this is these are free. You can download them if you're a DEMA member. Okay, what about changes in dive training? The main issue with dive training is how do we do an out-of-air drill? Because as you know, when you're taught to do, you've got an out-of-air diver, you pass them regular. Oftentimes people pass the primary that's just been in their mouth because that's the one that out-of-air divers know is working, so they're going to tend to go for that one anyway, or pass off their alternate or whatever. So in one agency, this is what was designed by RAID. They came up with this first. Lots of other agencies have followed with their own kind of nuances to this. But in general, what people are usually doing is having the out-of-air diver get past the primary or the alternate goes to the out-of-air diver. But rather than that diver then putting that regulator into their mouth, they hold that in their hand and then switch to their own alternate second stage. So the idea there is it maintains, it's not ideal, obviously, but it does maintain some muscle memory of someone passing them a regulator and of them changing regulators, but should provide some safety against infection. Now you could say, well, wait a minute, I thought you just said that the pool would inactivate everything, so why do we need to worry about this in the pool? Well, the issue is everything you do in the pool, you want to do in open water. So if you're going to do it this way in open water, you'd want to do it this way in the pool as well. Another thing that some people have brought up, which is mainly more for consumer confidence than true medical stuff, would be having students purchase their own mouthpieces to go on the regulators they use in training. So they switch off between training. The problem, of course, with that is it's not just the mouthpiece that's the problem, but the entire second stage could be infected if it wasn't adequately sterilized. But anyway, just other options that people have kind of come up with. Okay, finally, if you're unfortunate and someone like me and ended up catching the virus, when is it safe to return to diving? Currently, we can't make any really firm recommendations because there's just not a lot of data out there. The problem is, back a couple of months ago, there was a report from a very well-meaning physician in Austria by the name of Dr. Hartig, who published his experience in Wet Notes, which is a diving publication in Europe. That publication then got posted on Facebook and went wild and scared everyone to death. I want to emphasize this has never been published in a medical journal. This was published in a diving publication and then taken to Facebook. The report was of 6 patients who were non-hospitalized divers out of what was called, quote, dozens of COVID-19 patients that Dr. Hartig had taken care of. All of these patients had felt well 6 weeks after their symptom resolution. They were then looked at by him. 2, he said, showed hypoxia under stress. That would be basically probably exercising and having a pulse oximeter that dropped their oxygen saturation. 2 demonstrated reactive airway disease, which is basically asthma. So they, with exercise, developed some exercise-induced asthma type symptoms or test abnormalities. And then 4 showed what he called, and we don't have a lot of data on this, just what was reported, quote, impressive lung changes on CAT scan. And we know that lots of pneumonias can lag clinically, can get better much faster than CAT scans, and chest x-rays get better. The problem was, and I don't think this is really how it was meant in giving Dr. Hartig the benefit of the doubt, I don't think this is how it was meant to come across, but being translated into English and posted on Facebook, the report was that the author concluded that there was irreversible lung damage and that these divers would never be able to dive again. Well, that scared everyone to death. And you really, coming from a medical background myself and being involved in medical research for 30 years, you can't make any kind of conclusion based on 6 divers out of God knows how many divers that have gotten this disease. And you certainly can't say that because of something that happened 6 weeks after their symptoms resolved, that they will then never be able to dive again. You can't make that kind of sweeping kind of conclusions. And this became so out of control that the Undersea Hyperbaric Medical Society had to come up with their own statement. This is the Undersea Hyperbaric Medical Society position, uhms.org. It's on their website. And this was their report. They said, at the present time, we do not have sufficient data to support or refute the proclamations made by the case series from Dr. Hartig. The list of potential variables related to how this disease manifests, its clinical course and long-term prognosis is lengthy and may include factors such as underlying medical conditions, age, disease severity, and secondary complications. Case reports, which is what this was, which is a series of 6 people. Case reports suffer from multiple design weaknesses to include a lack of controls, lack of randomization, and this makes any conclusions suspect. And then while these findings are indeed disquieting, it will take time before potential impact on individual health and any lasting effects on lung or heart function are captured in the peer-reviewed medical literature. So basically what I was just saying, which is this is concerning when you see this, but don't make any sweeping judgments and sweeping conclusions based on 6 divers. So what data do we have? We don't have any data yet on SARS-CoV-2, the COVID-19, but again, we do have some data from CoV-1, which is again the SARS virus from back 2002, 2003. There was a report in the European Respiratory Journal in 2004, if that's the reference if anybody wants it. They looked at 46 survivors 3 months after their hospital discharge. So these were all people who've been sick enough to be hospitalized, and they looked at 3-month follow-ups. About half the patients had absolutely no abnormalities whatsoever on pulmonary function tests. The other half did. They had these acronyms you see down there, FVC, FEV1, and so forth and so on, are just markers of lung function. But the bottom line was, while 50% of people did have some abnormalities, all of these were mild except for 1 case. So they really only had 1 case of severe respiratory problems out of 46 people who were 3 months out from hospital discharge. So these are people who were sick enough to be in the hospital, and by 3 months, only 1 of them had serious lung problems. So hopefully, the SARS-CoV-2 virus will act more like this. We don't know that yet, but time will tell. There actually is some recommendations that have come out by the Belgian Society for Diving and Hyperbaric Medicine. I'll be honest with you, I did not even know there was a Belgian Society for Diving and Hyperbaric Medicine. They decided to be very conservative in their recommendations, which is always a good idea. Their recommendations are the following. Divers who have had COVID-19, they say should wait a minimum of 2 months, preferably 3, before resuming diving activities. And they say that because some people have taken over 30 days to get better, so they want to wait at least 2 months. And they recommend people who've tested positive or asymptomatic, they recommend those people wait 1 month before resuming diving. I want to emphasize this is just people's opinion. This is expert opinion. This is based on absolutely no data whatsoever. This is just a bunch of experts sitting around a table and kind of coming up with recommendations. There's also, they're concerned about the risk of pulmonary barotrauma because of the lung illnesses. So they recommend people who have been hospitalized, so they've had severe enough disease to be hospitalized, should wait 3 months. And then if you've been hospitalized, should probably undergo pulmonary function testing and a CT scan of the lung before returning to diving. Same thing, if people have been hospitalized because of the risk of those cardiac events like that weakened heart muscle I showed earlier, they should also, after a 3-month waiting period, undergo exercise stress testing and echocardiography, which is an ultrasound test of the heart to look for heart muscle function. They also brought the fact that since we don't know much about pulmonary oxygen toxicity in the setting of these abnormal lungs, they recommended breathing hyperoxic gas should be avoided. That mainly would be for rebreather divers. Nitrox is not a problem because you're not breathing that high at partial pressure for very long. And also they recommended being very conservative because we, again, don't know what the effectiveness of the lungs that have been diseased are at off-gassing. So recommend being very conservative on your computers and staying well within the no decompression limits. So this is my bias. So this is when can someone safely return to diving after contracting COVID-19. This is my bias as of June 2020. My first recommendation would be get your diving information and recommendations from organizations like Divers Alert Network, Undersea Hyperbaric Medical Society, and the South Pacific Underwater Medical Society, and not from social media. Don't get your diving recommendations from Facebook. Most likely, as far as returning to diving, this is not going to be a one-size-fits-all scenario. It's going to be very individualized, and that's because the signs and symptoms of the disease are highly variable among patients. So in my opinion, I think everyone who contracts this disease should have returned to their normal level of fitness, which assumes that every diver had some sort of exercise regimen before the illness. So this is my kind of plea to everyone that if you're not diving, everyone should exercise. I've always said that you exercise to get in shape for diving. You don't dive to get in shape. So if you've got a normal level of fitness, you know that you can walk a certain distance at a certain time, or you've got certain times on the treadmill or Stairmaster or whatever. Make sure you can get back to that level of fitness before you even consider going back to diving. And then especially anybody who is sick enough to be staying at home, or definitely if they've been hospitalized. But all divers, I think, should be evaluated by a physician knowledgeable in diving medicine prior to returning to diving, so they can make a case-by-case evaluation as to whether or not somebody could return to diving right away, or if they need further testing. You can imagine if you had somebody who said, yes, I got this disease, I was sick at home for a couple of days, I now feel fine, I previously was jogging 5 miles a day, I'm now back to jogging 5 miles a day, that person could probably return to diving right now. If you had somebody who never had much of an exercise plan, they were hospitalized for a prolonged period of time, they're still fairly short of breath, those people clearly should probably have at least pulmonary function tests, maybe a CAT scan of their lungs, and some sort of cardiac testing before returning to diving. So I think everybody with the illness should at least be evaluated by a physician. Doesn't mean they necessarily need more testing, but that can be done on a case-by-case basis. And I think, in my opinion, this is the best approach we have while we wait further data from well-designed studies published in peer-reviewed medical journals as opposed to in diving magazines and on Facebook. Dan, by the way, is organizing a study to follow divers who've contracted the disease. So if you or someone you know has had COVID-19 and is interested in participating, if you email them at medic@dan.org, they would love to talk to you, and they're trying to get a database to try and help all of us in the future kind of know how we should follow these things. Okay, so in conclusion, COVID-19 is a coronavirus, which is a serious illness with a mortality rate that's about 10 times that of seasonal flu. Most people have no symptoms or very mild symptoms, but a very small percentage can get very, very sick and even die, as we all know. It's spread by respiratory droplets. So to decrease the spread of the disease, we need to have social distancing because the particles in the breath will probably travel about 6 feet. Wearing masks does not keep you from getting infected, but can theoretically decrease the likelihood of you infecting someone else. So that if everyone's wearing masks, then they're also going to have a lower incidence of infecting you. Elderly and high-risk patients should probably continue to shelter in place as much as possible, even as we open things up, because again, we're going to get more people infected, and these are people at very high risk of mortality. People over the age of 80 probably have almost a 15% chance of dying from this disease. And then realizing realistically that as restrictions are lifted, there will be an increase in the number of cases, which is what we're seeing in lots of places these days. Individual divers, dive shops, dive charters, and training agencies all need to adapt and follow guidelines on disinfecting items, social distancing, etc. And return to diving after infection should be possible for almost all divers. The divers should be asymptomatic and have returned to their baseline level of fitness. And in my opinion, they should be evaluated by a physician knowledgeable in diving medicine to decide if any further testing is needed before they return to diving. And that should be it. I'm open to any other questions that any of you guys have.
Yeah, for those of you that don't know, you can plug your questions in at the bottom of the screen using the chat button, and Kelly will relay those on to Dr. Doug.
I do have one question from Paula. She's
Okay.
Liveaboards. What type of protocols are needed for this type of trip?
Okay, very good question. That's going to be on a case-by-case basis with the liveaboards, because obviously you've got a lot of people in a very small confined area. So again, the issue is going to be spreading people out. So I would imagine that the liveaboards will probably have to have fewer people, because the liveaboards, at least I've been on, when you're setting up your gear, you're pretty much shoulder to shoulder with most people. There's, every other tank is yours or somebody's. So probably need spreading things out. They'll need to make sure in the dining rooms that you've got enough distance between people. So again, that probably will require either spreading out tables or having fewer people on board. Again, you can't have the communal rinse buckets and so forth. So again, that's going to be a problem, but that's what they're going to do. Rental gear, same kind of thing as far as disinfecting. Everyone's going to have to disinfect their own masks and so forth, keep things apart from each other. So yeah, I think it'll be much easier to start up land-based diving than it's going to be liveaboard diving, just because of the logistics and being in close quarters with one another.
Thank you. Gregory asked if there's any data on the spread by contact on a solid object like gear or surfaces.
That data, I think, is still in flux. There was initial concern about the about how infectious this was off objects. That's why things were getting wiped down constantly and so forth. Then we kind of had a period of time where people said, well, no, that doesn't really happen. And now we're kind of hearing some cases that maybe it does. So it's mainly spread by respiratory. So mainly if you can cover your mouth and your nose, not touch your face and eyes, then that's probably going to be the best thing you can do. There may be some small chance of getting infected off an object. It depends on the type of object, how long it can stay alive. But I think the personal opinion, the days of us having to have stuff delivered and sit in the garage for 3 days before anybody would touch it, I think that's not likely to be of any real benefit. So main issues are respiratory. So social distancing and masks, for the reasons we talked about, probably the best things. So the more you can stay away from crowds, the better. And that's pretty much it. Underwater, you're safe. So that's the best thing to know. You got a mask on your face, a regulator in your mouth, your social distance. You're not going to spread anything. So we should all be diving as much as possible.
So we're going to wear our dive gear on the airplane.
Not a bad idea. Put your mask on. I've actually got one of my colleagues, not in my group, another cardiologist, has threatened. He hasn't done it yet. But there's a dive shop in town that, those the full face mask snorkel things that look like death traps to me. The full, for people who don't want to get their face wet, they got like little unicorn snorkel thing coming up the top.
Mm-hmm.
One of the dive shops in town has actually made one with an N99 filter on the top. So he's threatening that if he's going to have to come in and do certain procedures, he's going to wear that with a little filter. And I guess the filter is good for, I forgot how many hours. He told me 96 hours or something. You can switch out the filters. So He'll look pretty goofy, but he says he doesn't care. And if he's going to fly anywhere to Europe, he says he's going to wear on the plane as long as his wife's not with him, because his wife won't let him wear it. But if he's flying by himself, he says he's wearing that mask.
That's a great idea. I have another great question from Brian. What do you think the concerns are for adaptive divers, considering the closeness and touching and, you know, getting in and out of the water? What thoughts do you have there?
I think that's going to be like anything else. It's going to be a risk-benefit ratio. You know, anything in life is about risks versus benefits. So yes, clearly they're going to be at higher risk because by definition, you have to be closer to those people. You have to be in close contact. You've got to help get them in the water, get them out of the water. It takes more than even one person to do that lots of times. So that individual adaptive diver needs to accept that increased risk, and the buddies working with them need to accept that risk. So if everyone's aware of their mildly increased risk and wears their masks and so forth to try and keep things as low as possible, and they're all willing to accept that, I think that's a very reasonable approach. Thankfully, not all, but thankfully, most divers are younger and healthier than lots of other people in society. So you would hope that that person probably would be at relatively low risk of a problem. However, you know, if they're not very mobile, then they could be a high risk population. It depends on kind of what their adaptive problem is and how affected they are. But again, that's a very good question, and is going to be an individual case by case risk versus benefit among the buddies and the adaptive diver themselves.
I'm getting lots and lots of compliments on your presentation.
Oh, well, thank you very much.
And then everybody, I've got multiple questions about whether or not people will be able to view this later. Yes, we are recording. So once I have it downloaded, we'll get it uploaded to YouTube or something like that and make sure that everybody has access to that.
Hey, Doug, I have a question for you. One of my buddies that's on this call, Jonas, sent me an email earlier today about hyperbaric treatment for patients to reduce the possibility of them going on mechanical ventilation. Have you heard anything about that?
Yes, actually, yeah. They're first off, the sickest of the sick would not be probably possible, because if you're that sick, all the machines you're on and so forth will not be compatible with being in a hyperbaric environment, but because of fire risks and so forth. But the main issue is people who are moderately sick, and could you help them keep them from ending up on a ventilator? If you go to the UHMS website, there's multiple studies they've got listed. They're keeping track of all that. So there's actually multiple studies ongoing. We don't know the answer yet, but that's a hope. The hope is that maybe with hyperbarics, we could take people who are in the, say, moderate risk people and turn them into low risk people, or get them out of the hospital, or keep them off a ventilator. We don't know that yet, but there are multiple studies ongoing to look at that. That hopefully will be answered fairly soon.
One more question from Taylor Richardson, who's actually the head of Sea Shepherd Denver. So thanks for joining us, Taylor.
Oh, good.
She said, or asked, excuse me, when looking for a doctor, what's the best way to find one that's knowledgeable in diving? Dan. Dan has a list of over 700 doctors across the country who have some training in diving medicine. Some of them are hyperbaric docs. Some of them are just doctors knowledgeable in diving medicine of a variety of different specialties. So the best thing to do is get a hold of Dan, not on their emergency number, but on the regular number. Talk with one of the medics and ask for a recommendation in your area, and they will give you a list of people who are in your area. I'll be honest with you. I mean, as a physician, if you're not interested in diving medicine, you will have no knowledge of diving medicine, because there's absolutely no diving medicine taught in medical school. So you've got to be a little careful, because we are all trained above all, do no harm. Okay, and that's what we should be trained. So if you have somebody who doesn't know or doesn't have a lot of knowledge about a given problem, we're going to err on the side of being conservative. So if you went to a doctor who doesn't know anything about diving and doesn't have an interest in diving, and you said, I had COVID-19, I was hospitalized, can I dive again? They're probably going to say no, because they're going to want to be conservative. They're not being mean. They're just trying to be conservative. They don't want to put you at any undue risk. So you can go to your primary physician, and if they are knowledgeable, that's great. But frequently that will not be the case, especially if you're not in diving hotspots. You know, you'll get a better chance of having that if you're in Florida or California, probably, than if you're in, middle of Iowa or Nebraska. But Dan has a list across the country. So
always, Dan is a great resource for everybody. I personally think everybody should be a member of Dan for a whole variety of reasons, not just their emergency services, but their research and so forth and so on. So yeah, contact Dan, and that's be the best place to find somebody.
Awesome.
Where is this beautiful dive site?
Which one? Oh, the one that I showed you before, or the one right here on the picture?
Yes.
Okay, this is in a cave in Abaco, Crystal Caves of Abaco. This is that's on the picture. That's Brian K. Cook on the right in the yellow helmet, and my buddy Woody Alpern on the left. This is actually not very far back. This is about 500 feet back in a cave. There, you go into the middle of the jungle. Actually, it's a pine forest, middle of a pine forest, and it's about 500 feet back. That's all crystal. So a lot of these things, as opposed to rock, these things will light up and glow different colors. There's lots of different, I took a variety of pictures while I was in there. There's one that's beautiful, but it's about, I think it's 3,500 feet back into the cave. So it's a long swim back at depths of 165 feet at some places. So it's kind of an hour swim in, hour swim out, and an hour of decompression. This particular spot's only a few hundred feet in. So this is an easy one, an easy picture to take if you're a cave diver. Though we lit it up with 60,000 lumens of light. There's two 30,000 lumen video lights. If you see the one down the bottom right, and there's one on behind the thing on the other, along with the diver's lights. So it took a lot of light to kind of light this up.
Beautiful.
You have any other questions, Kelly?
I had one more about, this might be a little bit political, but do you support the use of hydroxychloroquine?
No, it's been proven not to work. So
Cool.
there had some good ideas behind it. It seemed like it might be a reasonable idea. I think everybody appropriately said, wait till we have data. A lot of people didn't wait till we had data. And unfortunately, a lot of people who needed hydroxychloroquine for other reasons had trouble finding it. And then multiple studies have come out showing no real benefit. So I don't think it has any real benefit. This is a viral illness that for right now is treated like any other viral illness. First, try not to get it. And secondly, if you do, rest, push fluids, and acetaminophen and Tylenol and so forth if you need it, and so forth and so on. And hopefully, and if you develop any kind of respiratory symptoms where you're getting short of breath, get seen by medical, that's the time to see a doctor right away. While we all wait for a vaccine, which we hope works. We'll wait and see. I'll tell you that social distancing can work. Again, I was sick for a week or 10 days. My wife is also a physician. We just basically wore masks in the house. We lived it's a 2-story house, so she lived on one floor, I lived on the other floor. We had meals together, but we made sure we're more than 6 or 8 feet apart. We watched Netflix together, but we watched on separate couches, so we're far apart. And I've obviously recovered and tested positive with antibodies. She got an antibody test a couple weeks ago, and she's antibody negative, so she never got infected, despite living in the same house with me for 10 days while I was sick. So, if you practice good social distancing and wearing your masks and so forth, you can be in close contact like that for somebody and still stay healthy. Or she got really lucky, one of the two.
That's great. Glad to hear. Lots more compliments pouring in. Doug, thank you so much.
Oh, thank you.
I really want to thank you, Doug. We're getting a lot of applause icons from people. Doug also has a bunch of other presentations that he's offered to do for us that we might hit him up for in the future, but I'll let Kelly's got a couple of them on, a couple of other ones I wanted just to tell you about briefly that we have coming up.
Yeah, thanks everybody again for joining us tonight. On Saturday, this coming Saturday, we are doing a virtual screening of Disney Nature's Oceans to kind of help get you into that ocean vibe, even though we can't quite get into the ocean yet. And then on July 11th, we are going to have marine biologist Mara Hart, who's going to do a similar kind of presentation like this. If the name sounds familiar, you may have seen her at the sale, I believe it was last year. She's the author of Sex in the Sea, which is a super cool book. So we're excited to have her again. So keep an eye out. Follow us on Facebook. Read those email blasts. All the good information's coming that way.
Yeah, and thank you everybody for participating. There's the book.
There it is, Jonas.
Really appreciate everybody jumping in. We had about 40 people on the call, which is amazing. And Doug, I can't thank you enough for your time and your wealth of knowledge and being willing to share that with our friends and clients here in Colorado. So.
Oh, happy to do it. Thank you so much for the opportunity. And like I said, if I can do something that can be helpful in the future, please reach out to me. I'd be more than happy to do it again.
That's great. Thanks again, guys. Appreciate it.
Thanks, everybody. Thank you.
Everybody have a good weekend and a happy Father's Day to everybody.
Yeah, you too.